We welcome you to Infectious Insights, a case series designed to discuss challenges and offer solutions for difficult-to-treat gram-positive bacterial infections. My name is Theresa Human, and I'm a pharmacist and a medical science liaison with Cumberland Pharmaceuticals. And today I have with me Dr. Joseph Reilly. Dr. Reilly is an infectious disease clinical pharmacist and the program director for residency in AtlantiCare Medical Center in Egg Harbor, New Jersey. Welcome, Dr. Reilly.
Thank you.
I'm going to review a case that you probably have seen and then ask you some questions. Joe M. is a 65-year-old male with a history of osteoarthritis in his right knee. He undergoes a right total knee arthroplasty and experiences pain and swelling around the incision site on postoperative day 4. He reports to the hospital and is admitted for intravenous antibiotics. The patient is febrile and has an elevated white count, ESR, and CRP, and his right knee is inflamed and tender to touch. He is sent to the operating room for wound debridement and surgical site, and blood cultures are obtained. Patient is started on vancomycin and cefepime. ID consult recommends discontinuation of current antibiotics and to initiate telavancin for better biofilm penetration. Less than 2 days later, the patient shows clinical signs of improvement. Blood cultures reveal no growth to date, and wound cultures reveal MRSA susceptible to vancomycin with an MIC equal to 0.5. The patient is discharged at this point for 6 weeks of OPAT therapy with telavancin. So, Dr. Reilly, after reviewing this case, what makes this case really difficult to treat?
You can see this is a patient that just had a surgery, so it's a post-surgical infection, which is always a concern. And the fact that the pathogen is Staph aureus is certainly a concern. Staph is associated with relapses. Now that we have this knee in place, this abiotic material, there's concern that the bacteria can now adhere to this material, and it makes it much more difficult to treat infections like this. So hopefully the course can be, they can be treated and you have a positive outcome. But in these cases, it's not uncommon where patients have to go back to the OR, have another surgery, and maybe have the hardware removed at some point.
Why do you think that in this case, the ID consultants switched the patient to telavancin from vancomycin and cefepime?
Well, I think in this case, we've seen the patient was on vancomycin. They had a prosthetic knee in place, and they're not getting better. So the vancomycin is not doing what it's supposed to. With the ID consult, I imagine they want to use telavancin because they're concerned about biofilm. And we always need to be concerned about biofilm, particularly with Staph aureus, particularly when there is a prosthetic material involved. Staph aureus can form biofilm on a prosthetic knee like this, and it can form biofilm on biotic surfaces like a valve of our own. So the treatment of biofilm infections is a particular concern. We have cultures and susceptibilities that do not tell us about the particular bacteria within the biofilm. So that planktonic bacteria that we're checking susceptibilities on are not representative of the sessile bacteria that have adhered to the prosthesis. They're not representative of that bacteria and maybe not very predictive of the outcome. So there's a lot of issues in a case like this, and we need to go with the right antibiotic. I think at this time, particularly since the patient did not respond promptly to vancomycin, that telavancin would be an excellent choice for the patient because of biofilm penetration.
This Infectious Insights series is brought to you by Cumberland Pharmaceuticals.